So good morning again, and thank you everybody for waiting for us. We can now start the first panel. As mentioned earlier on, the first panel is around public sector financing and private sector providers and experiences from Thailand, Japan, and the Philippines. We are very fortunate that we have three very experienced panelists here. We have Dr. Haruka Sakamoto, who is from Tokyo University. She's a primary care physician and a researcher at the University of Tokyo at the Department of Global Health Policy. Haruka got her MD from Sapporo Medical University and has been working as a clinician in Tokyo for a few years before she did her MPH at Harvard. And then she has also done a PhD at Tokyo University. In the meanwhile, she has worked for departments of international cooperation at Ministry of Health, as well as collaborating with WHO, World Bank, JICA. And her current research is on the politics of global health, especially in public health emergencies and UHC and aging society. The panelists to go with Haruka, we have Professor Manuel Derrit. Professor Derrit is the Dean of the School of Medicine, Ateneo School of Medicine. He's got a long history in public health. He was the Secretary of Health in early 2000s in the Philippines. He's also worked in the NGO sector, academia. He was director of the Department of Human Resource for Health in WHO in Geneva. And since I have known him, he's been the dean at Ateneo. And then we have Ms. Anika Sloan-Marshall, who currently is working at IHPP. She also has her master's from Harvard and currently working on different projects and programs within the IHPP and also internationally for IHPP, covering around health financing, universal health coverage, and vaccines. She's also pursuing a PhD at the same time at the London School of Hygiene and Tropical Medicine. The way that we'll work, if that's okay, is that Haruka will give a presentation, and then we will have a panel discussions around that issues, and then we will open to questions and answers. And we have approximately 1 hour for this session. So we have plenty of time to build the conversations and build the arguments and move forward on those sessions. So without further ado, I'm going to hand over to Haruka. And let me know if you need access for sharing your slides.
Thank you, Nima. Yeah, I can access. Yeah, thank you. Can you see the presentation slide?
Yes.
Okay. Yep. Good morning, everyone, and thank you very much for inviting me today. And then thank you, Nima, for your kind introduction. So my name is Haruka Sakamoto from the Department of Global Health Policy, University of Tokyo. So today in my presentation, in the first half, I'd like to explain about the overview of the research entitled The Role of Private Health Sector in the UHC, Challenges and Opportunities in Asia. And in the later half, I'd like to explain about the Japan's situation about the private health sector participation in the healthcare system in Japan. So let me briefly introduce about our research scope. So this is the to analyzing how the private health sector role contribute to the healthcare system in each countries. And then selected countries are the Japan, Republic of Korea, Thailand, and then the Philippines. We selected these countries because the two are the high-income countries, and then the two are the middle-income countries, and then they are very different stage of the universal health coverage, as well as the different situation about the public and private mixture in their healthcare system. So there are several purposes of the studies. One is to review and then analyze the size and profile of the private sectors in relation to the healthcare sectors. So as I mentioned, among those 4 countries, the participation of the private health sector laws varies among the countries. Second purpose is to review and then assess the purchasing method used by the health insurance agency, which purchases several services from public and private providers. And third purpose is to identify similarities and differences among the contractual agreement between public and private services. So in this case, purpose, so we like to analyze what is the contractual agreement both between the central government and then the public providers. Fourth purpose is to understand the reasons behind those similarities and differences, and then to assess regulatory tools that are used to enforce public and private contractor providers on quantity, price, and then quality of services. And then last purpose is to assess the effectiveness of these tools and the institutional capacities in the enforcement contracts. So we did the questionnaires and the key informal interviews in the respective countries. And then the key questions in our researches are following. So what are the proportion of privately owned healthcare facilities? So in each country, there are many private healthcare facilities, but its proportion is again largely differ among the countries. So first, we'd like to assess what are the proportion of the private healthcare providers among the countries. And then yes, next is what are the sizes of and the tolerance in the private sectors. So what is the tolerance of the number of the private healthcare hospital and the private care clinics? And then are there any major changes in the size and the tolerance in the private health sector? And then how does one characterize an evolution of market change to maximize efficiency, market share, and then profit margins? And then are there any differences in the contractual agreement between public and private medical institutions? So if there's any major differences, what are they? And then why do such a difference exist? And then are there any interventions done by the central or local government in order to mitigate those differences between the public and the private? And then our next key question is financial situation in privately owned healthcare facilities. So in general, it is believed that privately owned healthcare facilities is thought to be a financially good status, but we also would like to assess any differences in terms of the healthcare financing between the public and the private, and then especially for the privately owned healthcare facilities, we'd like to know about the details about the financial situation. And in proportion of privately owned training facilities for human resources for health. So again, in general, physicians and nurses and other healthcare professionals prefer to work in the privately owned facilities because it believes that they are providing better working environment. But we also would like to assess what are the major differences in terms of working condition and the training opportunities, both between public and the private. And then, yes, and then the last, yes, so these are the four main areas in the focuses. One is in the governance. So as again, what are any difference in terms of the governance and regulation for the private healthcare facilities? And then next is in financing. So including the healthcare insurance companies. So are there any major difference in the financing scheme, both public and private? And then fourth in the service provision. So what are the types of service providers? And then what are the difference in terms of the quality of the healthcare provided, both public and private facilities? And then lastly, about the healthcare workforce. So these are the overview of our research. And then next, I'd like to explain a bit about Japan's context. So I think some of you may already know, but Japan has characterized by the two universal health insurance system and then the uniform fee schedule. So one is about universal health insurance system, which is established in 1961. So those who are living in Japan for more than 3 months, regardless of their nationalities, it is a mandate for everyone to join the universal health insurance system. However, once you are enrolled into the universal insurance system, you have the secured access to the healthcare services with an affordable cost. So it depends on your age and then annual income, but usually the out-of-pocket payment rate is set at 10% to 30%. Another characteristics of the Japan's context is a uniform fee schedule. So government, the Ministry of Health and Labor and Welfare determines the price of healthcare services, which are revised once every 2 years. So the Ministry of Health decide all the prices of the healthcare procedures and medicine. And then these publicly defined fees apply to the both private and the public healthcare facilities. So for example, like if you take a CT scan at the private healthcare facilities or public healthcare facilities, in that case, prices are exactly the same. Or if you are hospitalized due to the appendicitis operation, in that case, again, the price of the hospitalization, including the operation fee for the appendicitis, are exactly the same, both private and then public. So thanks to the uniform fee schedule in Japan, it is believed that the price and then the quality of the service provided at the public and the private are almost equal. And then also the universal health insurance system, even you go to the private healthcare facilities, if you are enrolled into the universal health insurance system, in that case, even if you go to the private healthcare facilities, you only to pay a certain amount of the healthcare cost, which is usually 10 to 30% of the total cost. Okay, next, I'd like to explain a bit about the governance of the private healthcare facilities in Japan. So the Ministry of Health, Labor and will have the strong control over the private healthcare facilities in every aspect. So as I explained in the previous slide, the price of the healthcare procedures and the medicine are all decided by the Ministry of Health. So even at the private healthcare facilities, they do not have a decision to decide the price of the procedures they provided at their own clinics. And then, of course, there is a strong monitoring and inspection, both by the central and the local government. However, there is no major difference between the public and the private healthcare facilities. So regardless of you are public or private, you are regularly monitored and then inspected by the central and the local government. And then in terms of the monitoring and inspection system, there's no difference between the public and the private. And next is about financing. So again, thanks to the universal health insurance system and then the fee for schedule system, out-of-pocket payment rate is the same between the public and the private, and at around 10 to 30%, depends on your age. So if you are very rich and then you prefer to go to the private healthcare facilities, or if you are not rich, but still you can have access to the private healthcare facilities because the price of the services provided are exactly the same between the public and the private. Yeah. So because the insurance coverage is almost 100% here in Japan, which means everyone living in Japan enrolled in universal health insurance system, which are managed by the Ministry of Health, there is a very limited space for the private insurance company to join. Okay, next, I'd like to explain about the service provision in terms of the private health sector facilities. So in 2016, there's more than 8,000 hospitals privately owned here in Japan. It is more than 80% of the hospital and clinics are privately owned. And then the majority of the large size hospitals are publicly owned, while the most of the small and private clinics and hospitals are privately owned. And then the usually large size tertiary hospital, which is in a publicly managed hospital, are caring for the acute and tertiary care patient, while the majority of the private healthcare facilities are dealing with a non-acute care or the long-term care. There's no official data or research, but it is believed that the quality of care provided both in public and private are the same. Yes. And then lastly, about the healthcare workforce. Yes, again, there is no difference between the public and the private. So once graduate from the medical school or nursing school, the people are freely to choose in the public and the private. However, because of the private, because of the price and then the financial situation isn't exactly the same between the public and the private, usually the salary is also the similar between public and then private. So the physician or nurses purely to choose which healthcare facilities they would like to train in terms of their specialty or location. Okay. So thank you very much. This is a brief explanation about our research and then also the situation in Japan about private healthcare facilities. Thank you.
Thank you, Haruka, for that overview of the research and also situation in Japan. I would like us to just to start the conversation, if that's okay, along two different lines. It would be good if both Manuel and Anit could come in with some of their experiences and some of their findings across the same four areas that you talked about. You know, the issues of the governance and HRH and financing and service provision. And then maybe we can have a conversation around similarities and the differences that exists between those four. And then we'll open the floor to Q's and A's. Manuel, may I ask you to start? Let me put up this slide so that it helps for everyone, I think.
Okay, so thank you, Nima.
And then you can go ahead and talk over it, if you like.
You know, I have some slides, so if you
share,
you do.
If go I ahead. Can, please. Yeah, no, fill it. Go ahead.
You can allow to share my screen. Well, first of all, maybe just to greet the audience. I understand that mostly Department of Health people, so very happy to be here. Just a very quick background. You know, we did this research, a couple of years ago. And so I'll show you what we found. And I'll share my screen now. Okay. Inima, is this clear?
Yes, it is.
Okay. So, well, thank you very much, Haruka, for setting that framework, which we can use. I've actually sort of developed my reaction along the same lines. So maybe just to start, that really the topic we're discussing here is public sector financing and to private sector providers. And therefore, that was the focus of my preparation. But I can talk about those four areas as well: governance, service provision, HRH, and financing. But, you know, this is a slide from Asia Pacific Observatory about 2 years ago. And as you can see, really the Philippine health agenda already put private sector squarely, you know, at the center, particularly since the Philippines is a mixed system. But as I often explain it, the public and the private sectors in the Philippines really are like two different continents. You know, they go their own way. If there's any interaction, it's the flow of patients back and forth. But government regulates supposedly the private sector the same way it regulates the public sector. And I'd like to, you know, if there's somebody from PhilHealth here, I'd like to have them explain how they regulate private versus public. But the whole idea for healthcare delivery towards the future in the country is to engage the private sector more, you know, effectively, and to create service delivery networks that would have fixed co-payments in order to put a cap on out-of-pocket expenditure. And also to expand those services through a contracting process. This is the vision. But actually much, much harder to do. And I'd say much harder to do because somehow there is this tension between public and private sector. And public sector has very, very big suspicions about the way private sector works. Always thinking that contracts are going to be disadvantageous to government and so on and so forth. And therefore, even the administration of procurement of, you know, private sector services and supplies is very, very difficult to manage. But having said all of that, the whole idea is to eventually move towards good governance, okay, with this mixed public and private sector system. So these are the questions that Haruka posed, and I'm going to go through them. Essentially, again, try to discuss the size of the public versus the private sector. And I'm going to go through most of these and hopefully open up to discussion. So very quickly, what's the size of the private sector providers vis-a-vis the public sector counterpart? We don't normally think about this, but this gives you an idea, okay, of the size of the private sector. The headline is the private sector, particularly the hospital sector, general hospitals, comprises about 66% of the total healthcare sector. Compare that to Japan, where in Japan, it's actually 81%. Okay, but if you look at this table under here and you look at the share, and I only have it for level 1, level 2, level 3 hospitals. And as we all know, level 3 is the top hospitals. These are, you might say, the most sophisticated. Okay, for those that are not know the Philippine system, the regional hospitals, for example, would be level 3, where they're teaching and training. Level 2 hospitals are departmentalized, and level 1 are not. Okay, but if you look at all of these, the numbers here, you'll see the share. Level 3 hospitals, it's predominantly private. Level 2, predominantly private, and you can see most of the private hospitals are actually level 2. They're not teaching training. And level 1, predominantly public. Many of these would be district hospitals in the provinces. Specialty hospitals, I think there are about 10, but they're predominantly public as well. And many of them are in Metro Manila. For example, Heart Center, Lung, NKTI, Children's, Orthopedic, San Lazaro. This would be the specialty hospitals. So this gives you an idea of the share of private sector of our health system. And it's large. And when you look at the OPD, you can see it's mainly private. Okay, mainly private. Now, I don't expect you to go through all of this, but to give you an idea of the number, just look at the top line. It's level 3, level 2, level 1, and then the bottom line. Okay. And you can see to the right, there are about 1,200 public and private hospitals. So that's just a figure I wanted you to recall. Okay. And these are distributed throughout the regions. So you might say that all of the regions are covered by public and private facilities. So what is the size now of public sector financing, and that's PhilHealth reimbursements, of private sector services? And in summary, it's this. For inpatient, based on the data that we had for 2018, the reimbursement to private facilities comprised 55% of total PhilHealth reimbursements. Compare that to outpatient, where the total reimbursements of PhilHealth was 90% of PhilHealth reimbursements in 2018. And I'll show you figures for that. Okay, this is hospitals, 2014 to 2018. Let's just look at 2018, okay? Private hospitals were reimbursed close to 60 billion compared to public of close to 50 billion. So if you look at that, that percentage of total, you'd say this is about 55% then of the total. Okay. And you can see that the pattern hasn't changed. Although you might say that the amount of reimbursement total has changed, but the proportion is the same. Now, when you look at outpatient clinics, and these are outpatient clinics, okay, and there you have it, dialysis clinics, ambulatory care, animal bite, TB dots, outpatient, you name it, primary care clinics. Look at the share of the private sector. compared to the public sector. And that's where I'm saying that's about 90% private sector. So really, we have a very, very, florid private sector. Now, what are the mechanisms then for regulating private sector facilities? Okay, and in Japan, it's very, very straightforward. No, prices are the same all throughout. No difference between public and private prices. Even the quality of the services, presumably, and Haruka was saying, they're probably comparable. I guess in the Philippines, a lot of debate on that, on whether they're comparable. In some levels, probably, but in others, probably not. For example, when you think of district hospitals, primary care, public hospitals, many of them undermanned, probably not at par with their private sector counterparts. But here, the mechanisms then for regulation of the private facilities usually begin with accreditation. It's accreditation by DoH, accreditation by PhilHealth. And now we know there's already a merger of DoH accreditation and PhilHealth accreditation. And therefore, this is the way you enter the system so that PhilHealth can reimburse you. And then once you're inside the system, there is supposedly this healthcare provider performance assessment system of PhilHealth. And that system provides you a bench book for quality standards. It asks for performance commitments, particularly for individual health service providers. It does claims processing, utilization review, and fraud detection. This is the way PhilHealth sort of regulates private facilities. Whether they do that to the same intensity of public sector, I asked that question of a PhilHealth director once, and he said, they're more lax with the public sector facilities than with the private sector. So in what directions now will public sector financing move and evolve? And I've mentioned this, okay, as UHC grows and is rolled out, contractual arrangements, supposedly. Now, I think the Philippines has to learn a lot about contractual arrangements and managing contracts, because public sector, doesn't manage this very well. And before you know it, there are scandals and you're hauled into the Senate and House hearings on corruption. And then, of course, there's public financing for primary care. Fee-for-service probably isn't going to work. And therefore, we know that PhilHealth has a consulta package where the capitation, even for the private sector, is 30% more than the public sector. In cognizance of the fact that the public sector primary care has a lot more support from government, which private sector primary care providers do not, and therefore an increased capitation rate for private sector providers. That's what we learned from PhilHealth. Whether this is actually being implemented, we'd like to hear from PhilHealth people on that. And then, of course, what are the prospects for strategic purchasing, where PhilHealth uses its capacity to procure to be able to drive down costs, as many governments do. Now, this is HRH, and this is unfortunately an unpublished reference, but this was just to give you an idea of the projections for human resources, okay? But in summary, if you're talking about doctors and nurses, there's almost equal distribution between the public and private sector, okay? But I think for midwives, it's predominantly public sector because they're the frontline workers. But we know that most of our practitioners in the private sector, practice in urban areas. And if you look at this study by Alige, where he projected the number of internists needed in each region and the actual internists there, he saw a lot of deficits, and these were mainly for internists. So think about, many of the provinces where, you're not near the actual number of health professionals that you need there. Production capacity, to give you an idea. Now, for medical schools, for example, what's the public-private mix? I'd say that private sector has 80% of production capacity. And we know now that government has mandated the government state schools, to have a medical school in every region so that they could produce doctors for that region. Now, I'm moving towards the end of my presentation, and I'm just going to show you some slides really from the Department of Health, which envisions the integrated local health system. Now, this is the public system, no? But you could draw here that you would include all of the private sector primary care facilities in an integrated system, referring to secondary care facilities, which could both be public or private, and a tertiary facility, which could be both public and private. But how will that integration work? Beyond just drawing it so neatly. Think about service delivery, and this is what the law says for individual-based care. PhilHealth to contract public, private, or mixed healthcare provider networks that would agree on service quality, co-payment and co-insurance, which would be fixed, and of course, submission of data. That system would have to be fully integrated, public and private. In thinking about population-based services, again, DoH would contract province and citywide healthcare systems. Now, these province and citywide health systems should have integrated with them private sector providers, because you have the private care provider network here, which would not only be public. And of course, the epidemiologic surveillance systems, which would mainly be public, and of course, health promotion programs. But these population-based health services, by law, would be funded from taxes, and the money would be coming from your General Appropriations Act. And this is the really tricky part for the health financing, because it's envisioned that you're going to have a special health fund to be managed by the province, or all of the funds from, for your population-based services would go into these funds, and all of the individual-based payments would go into these funds, including those for PhilHealth, from PhilHealth. And the province would then have to manage this fund to keep all of these services running, from the primary level all the way to the tertiary level. And as you can see, this is a public-private mix, where the public is labeled green and the private is labeled red. That's the vision. Now, I'm going to end with this, because one of the givens of the country is that we're an archipelagic country, very many remote and rural areas. How do you reach out and provide healthcare there? Mainly in these areas, it's public sector that provides healthcare, but can you entice private sector into these areas? There are private practitioners there, but how do you bring them in and integrate them into a very, very cohesive system? Now, this is just the map of Northern Samar, and I've encircled here as a remote municipality of Dolores, on the coast of the Pacific Ocean. And this is what it looks like there. Thinking about healthcare in these areas, And does private sector have a role here? If not, how are you going to strengthen public sector services there? Because, and this is my last slide, this is a letter from the municipal mayor of Dolores writing to an NGO. In this case, the NGO was the Committee of German Doctors, and the mayor was saying, healthcare is our primary concern. Unfortunately, our RHU and the only hospital that we have cannot cater to the health needs of the entire municipality due to its poor condition and lack of medical equipment and competent doctors. So going into universal healthcare, these are the challenges that the Philippines faces. Thank you very much. Over to you, Nima.
Thank you, Manuel, for a very comprehensive, detailed analysis as well. I have noticed that some questions are coming up already, and I'll certainly have some questions. But before we go to Q&As, can I ask if Annie can either give talk or if you have a presentation, whichever is easier for you, a little bit about the Thai situation, so that we have all the three countries together. We're talking about two countries which with a very strong private sector engaged, to a country that is far more looking at the public sector as the service delivery. But Annie, go ahead.
Great, thank you, Nima. I don't have slides, but I can definitely give you a quick overview of the Thai system. I think I'll start off with kind of an explanation of the role of the private sector in general in Thailand. In contrast to the Philippines and Japan, in Thailand, the private sector plays a smaller role as the public sector dominates throughout the country. Approximately only 16% of hospitals in the country are private. However, as our study has focused on, in many cities, for example, in Bangkok, private sector plays a much larger role. For example, in Bangkok City, there are 97% of private hospitals that are contributing here. So although in general and throughout the country, the public sector plays a larger role, in the major cities, the private sector does play a very significant role. Within the universal health coverage system, there are 3 health insurance schemes: the civil servant medical benefit scheme, social health insurance, and universal coverage scheme. So of these 2, universal coverage scheme and social health insurance allows populations to seek healthcare at private facilities. The civil servants medical benefit scheme only allows the civil servants and their dependents to seek care at public hospitals only. So both social health insurance managed by the Social Security Office and universal coverage scheme managed by National Health Security Office do contract with certain private hospitals to provide care, more significantly in major cities such as Bangkok. In terms of regulation, there are several regulatory acts, for example, the Health Facility Act of 2016 that set certain standards, requirements for licensing and relicensing, for example. In addition to these, however, both the National Health Security Office and Social Security Office have their own regulatory mechanisms when deciding on whether or not to contract with certain private hospitals. While all public hospitals are automatically basically contracted with, for private hospitals, each scheme does have certain requirements for health facilities to meet in order to be contracted, in order to make sure the quality of care and performance meets certain standards. So the Social Security Office, for example, uses hospital accreditation standards, or a JCI as well, using stepwise accreditation. They also have to meet certain requirements in terms of number of hospital beds, certain departments that have to be available at the hospital, and different services. And for the National Health Security Office, they do have their own quality standard control board that is a governing body of the National Health Security Office that sets and monitors certain standards of quality of care. In terms of service utilization, according to a survey from 2019, we found that only 20% of patients seek care at private facilities throughout the country. However, in Bangkok, the percentage is a little bit closer. So for outpatient services, it's about 42%, inpatient services, 55%, and health promotion services, 59%. So the percentage of public and private facilities is a little bit closer, whereas in general throughout the country, there is a less utilization of private facilities. So a big thing that we did find is basically the regulatory issues that are different between public and private hospitals. While, sorry, hold on. Can you hear me okay? I think my connection cut.
No, we can hear you fine. I can see you fine. You're not muted.
Hello,
Yeah, we
is
can
that
hear
okay?
you. Yeah.
Okay, sorry about that. I just got a warning that my connection was about to cut. I'm sorry, where am I? Yes, so some key regulatory issues that were discussed basically is that for private facilities, for example, very recently we found a case where, well, I guess to begin with is the payment mechanism. So both public and private facilities are paid in the same mechanism using capitation or DRGs and other payment systems. However, as we use capitation, we found that a lot of private facilities, as they are for profit and they need to gain some income, we found that they were registering what we call ghost patients using the Thai ID system, buying ID numbers, for example, and registering these certain patients within their capitation zone in order to gain a certain amount of financial benefits. Public hospitals, of course, as a nonprofit are not doing this. So this is definitely a big issue that we found that is very recent. The way that they've been trying to kind of address this is several different payment mechanisms to regulate the private sector a little bit better. When we interviewed key informants, we did find that although the Social Security Office and National Health Security Office want to increase the private sector role, the private sector were both interested but also hesitant. In terms of interest is that as they get paid by capitation, it almost guarantees a certain amount of income that come in. However, it is a lot of competition for the private sectors themselves as well. They are, in order to gain the capitation rates, patients have to choose to register, or in terms of scams, there are these ghost patients, but to be able to increase patients to come in, they have to rely on their own investment out of pocket for the investors within the hospitals. So the upfront costs for building these infrastructures is very difficult for them. Another issue that they found was that as the payment is done directly through the insurance schemes, they find that the auditing system or the way to reimburse costs is difficult. And as a result, many of the facilities, when audited, were found to have faulty kind of payment requests, for example. However, when we asked them the reasoning for this, it wasn't always intentional. It was sometimes unintentional. And they found that the process to reimburse costs were very difficult for them as well. So those were some of the major things we found. Both the private and both the National Security Office and Social Security Office are trying to increase incentives. For example, there are various schemes that have been introduced for private facilities, including certain certain I'm sorry, I'm trying to yes, so for example, if certain health facilities meet criteria for quality or patient satisfaction, they are able to gain bonuses as financial incentives following every annual check as well. I'm sorry, my computer is shaking, so I'm not able to, 1 second.
We can hear you
Sorry,
fine. But
sorry, okay. Yeah, sorry, Nima. If you have additional, I think you said there were some slides that I can look at to see how to kind of gather my thoughts a little bit.
okay, while you're doing that, let me ask, because we've got a couple of questions and they're coming towards Manuel. So let me ask those questions while you're looking at gathering your thoughts. Is that okay?
Yep, sorry. Yep, go ahead.
All right. I know. So we got a couple of questions in the Q&As. So one is, when we asked if private sector will also accept case rates without a co-payment, they were mum about it. Because they will just take advantage of the PhilHealth coverage. So I guess the question on this one is about, let me broaden it up. Are we expecting that they will still take co-payment in the private sector in the Philippines, even though they're not supposed to? Or are we going to have additional payments added? Is that something that is to be of concern when it comes to contracting with private sector? And the next question is, what is the, from the DoH side, what is the envisions for the network? It seems that only public hospitals, at least in the secondary and tertiary level, are included in the network. Wouldn't this exclude a major source of supply from healthcare services from the private sector? So Manuel, if you want to answer the second one, it's that's easier.
Yeah, thanks, Nima. I'll start with the second one. You know, where we're at now really is, I think, a lot of speculation going forward about how the networks are going to come together. For the private sector facilities and practitioners, their main concern really is how is their income going to be affected by these referral networks. You know, because it's a market situation. And therefore, if you're private sector and you're saying, if I entered this referral network and my income is going to be compromised, then I'd rather not join. And therefore, what happens there is you'll have a situation where the private sector facilities and practitioners who don't join, they're going to be cut out of social insurance. Okay, so there's that tension for them. So that's why I think that they're not saying anything, because they don't know how to react. And therefore, private sector, I think at the moment, they're comfortable with the situation where a proportion of the bill is covered by PhilHealth and the rest of the bill is paid out of pocket. And this is private sector, usually in large tertiary care hospitals, where their clientele can afford to pay the out of pocket. You're now going to have problems in your secondary, your level 2 hospitals, particularly in the provinces, where your clientele are going to be mainly poorer people or lower middle class. And therefore, what we'd have to think about now would be how you can drive down the costs, but maintain the quality. And therefore, I think that would be the from the public sector point of view, because public sector still, services anywhere from 40 to 80% of places outside of the urban areas. It's improving public sector facilities, which is going to be key to achieve your universal healthcare coverage. And to run those facilities very well, with high quality. But if you're going to do that, you'd have to attract people there, and have doctors who are good doctors who are going to want to practice there. And so it's work in progress, and therefore this whole policy of setting up medical schools in the regions so that you can train doctors who can practice in these regions, that's sort of what they're trying to bring in as another policy to secure your human resources for health. But I think to Dr. Liquete's point, private sector in the end, by the nature of private sector, will want to recoup its costs as well as have a certain markup so that they could improve their facilities and continue to provide services that are competitive. And so it's a totally different psychology there. And I think this is the challenge that PhilHealth has in paying them. Thank you.
Thank you, Manuel. Let me ask a question, and then one more question, and then I'll come back to Annie for you to finish what you were saying. It's Manuel and Haruka, and also you, Annie. Correct me if I'm wrong. Japan is doing fee-for-service fundamentally for the private and public sector, and what you're telling me is that it works. It's a challenge in the Philippines, and Thailand has never gone for fee-for-service. Why is it working in Japan?
Okay, so in Japan, fee-for-service is only applied for the outpatient care. And then for the inpatient care, we use the DPC, which is similar to the GRG system. So I think that usually in the outpatient setting, the price of the medicine or healthcare procedure is not such expense. So, so whatever the physician prescribe or doing any kind of procedures, usually the total amount of the healthcare financing is not such large. So in that case, probably government does not really regulate on that aspect. And then, I think this is a major point. But in the past, we apply for the fee-for-service in the hospitalization setting, but it is easy to imagine that because in inpatient care, it costs a lot. And then it is not sustainable in terms of the financing if we apply fee-for-service for the inpatient care. So that's why government changed the policy not to apply the fee-for-service anymore for the inpatient care, rather only limited to the outpatient care.
Nima, can I say something about that fee-for-service?
Yeah.
Okay. It's a mindset, huh? And there's a philosophy behind it. Because if you look at the Philippine system, fee-for-service is patterned after the US. And the whole philosophy of the US is that healthcare is not a right. In the US, you pay for your health service. It's not a right. It's not automatic. You have to pay for it. What has happened is that the fee-for-service foundation of the Philippine system has now been, you might say, is now being challenged by this concept that, health is a right and that all citizens, should have access to it. But the Philippine system can't afford to finance that right for everyone. The public system cannot do it. And therefore, you have this gappy system, which brings out the issue of equity and inequitable services, in different parts of the country. But it's essentially, it's really because of that tension between fee-for-service and human right, health as a human right, to be funded by public services. And therefore, where the Philippines is concerned, I think the challenge that the government has is to then, even as it's given the country this law that says health is a human right and you're all covered, what is now the role of the citizens in actually financing that system? And because you've got 20% of the population very poor, then you probably have to develop a system that's able to cater to both. But where, you know, people can pay for their services, they just have to pay for it as fee for service. And I think that's already what's happening. But you can't apply that fee for service system for the very poor population. And therefore, how to nuance the system so that it works, because you can't do fee for service everywhere. And in that municipality that I showed, certainly fee for service is not going to work. I think that's the challenge of the Philippine system. Virot has his hands up.
Viroj has his hands up. Viroj, come on in.
Hi, Haruka. I'd like to clarify, Japan did not use a conventional fee-for-service system. Actually, it is a modified, they call point system, like the Germany system. It's not a conventional open-ended fee-for-service. So in Thailand, we call fee schedule based on point. For example, Ventolin. Bangkok branch will pay, for example, 55 point, and 1 point is 1 baht. So that can control. Compared to conventional fee for service, they can expand both P and Q, both unit claim as well as quantity. For Japan's system, point system, they can only expand Q, which is quantity. More services to make more points. But the point is constrained by a fee schedule. Is that correct, Haruka? So that all the audience in the Philippines will understand correctly. It is not a fee for service conventionally.
Yes.
Is that correct?
Yes. Yeah. Yes.
And not many countries use fee schedule and point system. Taiwan, Japan, DoH, Germany. The remaining, and Iran, yes.
And it's a mess over there.
So what's
Thank
the
you, Virot.
advantage of the point system, Virot and Haruka? What's the advantage of the point system? Does it limit your costs?
Haruka first.
Okay, if I understanding correctly, so a point service, I mean, Dr. Viroj explained about the conventional fee for service in Japan, right? It is not, I mean, no, I mean, kind of the limitation for the service usage here in Japan. So yes, we use the fee for service for the outpatient clinic, but still there's some limitation for using the services. This is the situation in Japan. So there are two limitations. One is, as I said, the government deciding the overall price of the healthcare procedures. So once government decide, okay, so probably this year and then last year, so PCR testing or treatment for the fever or cough at an outpatient clinic is increasing because of the COVID-19. So in that case, if government would like to decrease the healthcare financing for those aspects, in that case, government decrease the payment for those services. So for example, in the 2018, if the price of PCR testing wasn't $2, for example, but if the government would like to control the overall financing, in that case, government decided to lower the price of the PCR testing in order to control the overall healthcare financing. So yes, we use fee for service, so physicians are freely to provide and doing any healthcare procedures, but in overall healthcare financing is controlled by the central government. And then also the physician, even he would like to conduct any kind of examination and prescribe the medicine, there's a kind of the monitoring system or inspection system. So if this kind of the monitoring committee do a monthly check for all the procedures conducted by the physicians. So they are checking if those prescription or if those are testing or if those healthcare procedures appropriate for that patient. So if the monitoring and inspection committee, so this is a not appropriate healthcare procedures, in that case, they are not reimbursed under the national insurance system.
Nima, can I?
DoH, please comment, and then I saw Manuel is your hand up, and then I would like to finish with Annie, and then we can go finish the session. Thank you.
Okay, yeah.
Go ahead, DoH.
Capitation, the downside is under service provision. So that means you get X dollar per year multiplied by population in your registry. No matter how many OP visit, you get that fixed amount. Point system is a modified capitation that you have to produce points. Otherwise, you did not have any dollar back in your purse string. So, and conventional fee for service, far right end, that they can produce both up price and up quantity of services. Then the multiplication of P and Q will make the insurance fund bankrupt.
Yeah.
Therefore, in the point system is a middle ground. I don't know, Haruka, 1 point, how many yen you pay in Japan?
1 point for what? You mean the 1 point visit?
Yeah, 1 point visit. How many yen?
300 yen. It's $3 to $4
per point.
Yes, yeah, per point visit.
So they have to make points. Otherwise, you don't have any revenue. Compared to capitation, they just keep the money without providing services. So the downside, the strength, but capitation works so well in public contracting model because they are not profit-making entity. In district hospital, district health system, they did quite well. They go along very well with the optimum use of outpatient services. Back to you, Nima.
Thank you. Annie, do you want to have I have one more question coming in, but I would like to hear Annie finishing her presentation. That's okay. We are running out of the session time, but since the conversation is quite pertinent and good, I would like to continue with the next question. But Annie, do you come in first, finish your presentation, and then we.
Thank you. No, I guess I'll just very quickly highlight some key points. The first is why the private sector. As I mentioned previously in Thailand, the public sector does play a major role, unlike in many countries. But why is the private sector necessary is in certain populations, such as in Bangkok, where the public sector are not able to properly reach certain populations. So that's why they're necessary. So therefore, both schemes, social health insurance scheme and universal coverage scheme, they need to engage with private providers. And this has been done through several mechanisms. Well, firstly, capitation provides guaranteed money. Second would be location of these private facilities allows them to gain certain higher capitation rates. For example, they'll be established in industrial zones where they have factories and such for these factory workers to seek services there. Another is they themselves need to create their own name and brand in order to seek additional patients. So certain private facilities that are branded or have a certain name recognition, more patients are more likely to register with them. However, the key problems that we have found. So although in Thailand, both public and private facilities within universal coverage scheme are paid at an equal rate and through equal mechanisms, the financial risk that is put forth by private facilities is a lot higher. So public facilities are funded through infrastructure and medicinal purchases, everything through separate money, obviously through public funds. Private sector have to put forth their own risk. And additionally, they have to expect profit from it, which is very, very difficult for them if they're not able to guarantee a certain number of patients that join their catchment area. Another issue is going to be the capacity within the private facilities themselves. They will need to be trained to reimbursed correctly. They need to be trained to provide the care to the same standards that are required of them. A big discrepancy, even though the regulations aim for public and private facilities to regulate similarly, is, for example, for quality audits and financial audits. Both public and private facilities are audited the same way. However, private facilities are audited almost annually, maybe more, whereas public facilities are given 2-3 years, if that, to be audited. So private facilities are more at risk of being audited and face more fear in that sense. And auditing has found that in some facilities, they have mismanaged reimbursements and such, which again goes back to capacity of, were they trained to be able to reimburse correctly, and do they have the people and human resources to be able to request those reimbursements. We've found certain facilities that have maybe 5 or 6 doctors on rotation, so it's very difficult for them to manage human resources wise. And additionally, both private facilities and public facilities are required to conduct health promotion activities, which public sector is more able to do, whereas the private sector, they are not as able to in certain areas. So a lot of facilities have tried to create outreach programs using hospital vans to reach certain areas as well. But again, it's their own investment into the infrastructure. So I think that's my main thing, is that while there are regulatory similarities between public and private, there's certain differences for private facilities is enough for private facilities to feel hesitant and find it difficult for themselves to join and stay within the universal coverage system to provide services. I think that's my main point, Nima. Thank you.
Thank you, Annie. Thank you. We actually had an open question, but I noticed that Haruka answered it directly, and I understand that we are now 5 minutes over time schedule. So if that's okay, I would like to thank everybody who joined us, and thank you for the wonderful and robust conversation and the insights. We are hoping that we can publish this particular APO publication within this year, and we'll urge everybody to read it once it's published. So with that, I would like to close session 1.